Ma'am, Dr. Shalini Jain, ma'am, has emergency cases, so she will not be able to attend.
Okay. That's all right. You, ma'am, will also not be able to attend.
Sreedevi ma'am is not answering the call. I'm trying to reach her, ma'am.
We just take the program forward. It's 5 o'clock.
Yes, ma'am. One of us can chip in, not an issue.
So, welcome to this 43rd episode of Searchlight. This time, the Searchlight is on Precocious Puberty. It is by the Cancer Prevention and Relief Society, Chhattisgarh, in association with faculty from Bagalkot, Bhimavaram, Jalandhar, Raipur, Rajahmundry, Tumkur, and Vijayawada. Welcome everyone to this 43rd episode. I hope you will all enjoy the learning that we are going to have. The convener for this series is Dr. Sujayasri Sangita. She is a consultant obstetrician and lab surgeon at Sheshadri Hospital, Palakol and Malkapuram, founder secretary of Bhimavaram Obstetric Gynec Society, secretary IMA Palakol. Her awards are, she has the Shane Ratnam Award, Young Gynecologist Award, Foxy Veera Award. Her areas of interest are laparoscopy and infertility. She has many paper presentations, has organized conferences, and does a lot of community work under Vikasam for adolescent girls. So welcome, Dr. Sujayasri.
Yeah, thank you, ma'am. Thank you for that kind introduction.
I will call Kumudini ma'am for a second, okay?
Sure.
Over to you.
So, it gives me great pleasure to introduce the program director, Dr. Asha Jain, ma'am, who actually needs no introduction. She's currently the director of SMSA Hospital, Raipur, medical director, Cancer Prevention and Relief Society, elected member, CG Medical Council for the year 2020-2025, chairperson-elect, FOXY, Food Drug Medical Surgical Equipment Committee, president, Raipur Menopause Society, Chairman Mission Pink Health IMA Raipur, and also the executive member of IICCP Chhattisgarh ISAL chapter and Chhattisgarh SFM chapter. Madam has received colposcopy training. She has also received certification for FCCS obstetrics, IOTA certification. She has also been FMK UK certified. She's received training in colposcopy from AV School of Colposcopy, Chennai. And her areas of interest are preventive oncology and colposcopy, saving the uterus, fetal medicine, obstetric and gynec ultrasound. So I welcome ma'am to today's session and I ask her to please take the program forward with the invocation. Ma'am, please unmute yourself, ma'am. Please unmute yourself.
Any Shubh Karm starts with prayers to the divine. So I request everyone to join hands for prayers.
Vagratunda Mahakaya Suryakoti Samaprabha Nirvignam Guru Me Deva Sarvakareshu Sarvada. Om
Dr. Purvi Agrawal is the coordinator for this series. Today, she's not been able to join. Our chief guest is Dr. Kumudini Jha. Madam has joined. Welcome, ma'am. She is the president of Darbhanga Obstetric Gynec Society, an extremely senior gynecologist and a dear friend. She is ex-HOD, Department of Obstetrics and Gynae, DMCH, President, Darbhanga Obstetric Gynec Society, past clinical secretary of Darbhanga Society. She has papers in national and international journals. She is faculty in FOXY conferences and presented papers in several conferences, and is a speaker in CMEs and examiner of UG and PG exams. Welcome, Smriti ma'am.
Thank you so much, ma'am. Darbhanga Society. She has papers in national and international journals. She is faculty in FOXY conferences and presented papers in several conferences, and is a speaker in CMEs and examiner of UG and PG exams. Welcome, ma'am. Thank you so much, ma'am. Darbhanga Society. She has papers in national and international journals. She is faculty in FOXY conferences and presented papers in several conferences, and is a speaker in CMEs and examiner of UG and PG exams. She has papers in national and international journals. She is faculty in FOXY conferences and presented papers in several conferences, and is a speaker in CMEs and examiner of UG and PG exams.
Sujaya,
Yes, ma'am.
I don't know what's gone wrong.
Okay.
So I'm logging out and I will log in again.
Okay, ma'am.
Okay?
Yeah, so
Means I really don't know what's gone wrong.
we'll ask Kumudini to wait and then give her words.
I don't know what's gone wrong. Okay. So I'm logging out and I will log in again.
Okay, fine, ma'am.
Okay?
Yeah, so
Because I really don't know what's gone wrong.
we'll ask Kumudini to wait and then give her words.
I don't know what's gone wrong. Okay. I'm
Sujayasri,
logging out and I will log in again.
Yeah,
Sujayasri, better call ma'am on phone.
yes,
Something
ma'am.
is wrong
I'm
with
doing
you.
that. I'm doing that. Yeah.
Yeah.
Has somebody logged in from two somewhere? Sujaya, has somebody logged in from two devices?
Not that I see, ma'am.
Ma'am,
Now
everyone's
I
logged in
Somebody
from a
also
single
has
device.
the public one on, that is what is happening. So,
Okay.
Kumudini ma'am, would you please proceed? Sorry for that disturbance and that technical glitch.
Thank you so much, ma'am. Before I begin something on the topic, I can't thank you enough for giving me this honor. And this topic that you've chosen is definitely a very important topic, because every day we don't see these cases, but when they come, we have to actually know how to diagnose it. So first thing, we should know how to proceed, whether it is a case of this precocious puberty or not, because now the age has come down to 8 years.
అది
When you can
చూపించి
see
ఒకసారి
LRT.
పేమెంట్స్ ఇప్పుడు ఉన్నాయంటే రేపు చూపిస్తాం, ఇంక ఇప్పుడు అవ్వదు.
Hello. Hello.
Yeah,
Yes,
ma'am, you're audible, ma'am. Please proceed.
Okay. So we should always first diagnose whether she is. We should know that the first thing that is a visible sign is LRT. Now we have to also determine whether it is a central type or a peripheral type, because the treatments will vary. In the central type, we also know that the FSH and LH will be high, but the estrogen will be low. Whereas in the peripheral type, the FSH is high, LH is high, and the estrogen is also high. And the cause, why do we should first know why is it that it remains dormant, the hypothalamic pituitary axis, why is it dormant before 8 years? So because of the quercetin and the neuropeptide Y. So once the pulsatility starts, then it starts to stimulate the ovaries. And it can both be in the males as well as in the females. So it could be an isosexual type in which the features are that of the females. And in the male type, when there's the androgen is also high, then as happens in congenital adrenal hyperplasia or in circular cell tumor, then in those type of cases, you can get the heterosexual type also. So it is important and there could be a premature epiphyseal closure of the plates. So the height is also compensated. So the treatment is GnRH, but how do you give it? You give it continuously to suppress FSH-LH in cases of precocious puberty. And in delayed puberty, of course, it is GnRH again, but it is in a pulsatile manner. So we have to be very cautious when to give what and at what age. So age is again, the bone age is an important factor in deciding how to manage these patients. So we are going to hear about all this and much more from our learned speakers. So I welcome our speakers and the chairpersons. Thank you so much.
Thank you so much, Kumudini ma'am. You've been kind enough to be with us.
It is my pleasure, ma'am. It is my pleasure.
So now I would like to screen share again and introduce Sujaya.
Yes, ma'am. So moving on to the first session for today, which is Precocious Puberty. I will introduce the chairpersons for this session. We have Dr. Sreedevi Vellanki with us. Madam is a consultant at Sri Vijaya Maternity Hospital, Vijayawada. She is currently the president of Vijayawada Obgyn Society. She has previously been the vice president and secretary of the same. She is the first lady honorary secretary of IMA Vijayawada in the year of 2012-2014. She has also been the vice president of IMA Vijayawada, and she has been the founder secretary of APOGS, which was formed after AP bifurcation. She's also been the organizing secretary for Platinum Jubilee celebrations conducted at IMA Vijayawada. It's an honor to have you with us here, ma'am. The next chairperson is...
That's okay.
That's okay, yeah. So I request Dr. Sreedevi to please introduce the speaker for today, Dr. Uppal Saurabh. Dr. Sreedevi, ma'am.
Yeah, good afternoon, all. Good afternoon, all. Thank you for the nice introduction, Sujayasri. It's an honor to introduce today's speaker, Dr. Uppal Saurabh, MD Pediatrics. He's a gold medalist, MRCP CH UK. He has done his fellowship in pediatric endocrinology, SP fellowship in pediatric endocrinology, and he's presently consultant and director EndoKids clinics, Jalandhar, Ludhiana, and Amritsar. And he has about 10 original research publications, contributed to 8 textbooks chapters, and he has also co-authored guidelines in 2 books. His area of interests are childhood growth, advanced diabetes care, and diabetes technology. We are eager to hear from you, Dr. Uppal. Dr. Saurabh?
He will join shortly. I shall be playing his presentation first.
Good evening, everyone. First of all, my heartfelt gratitude to Dr. Asha Jain and her team for giving me this opportunity to present in front of you my learnings and my experience to sensitize you about a topic which is becoming very important very rapidly. So we're going to discuss why we need to bother about early puberty and when do we need to intervene in it. So picture this. You have an 8-year-old girl who walks into your clinic with her first period, and you think, thank God, there's one less period to worry about. But it is not normal because it has become a very serious issue just in the last decade. As per the latest evidence, I would just take you to your OPD, think about it, and then you answer this question. What do you feel is the mean age of menarche in Indian children? Is it 13 to 14 years? Is it 12 to 13 years? Is it 11 to 12 years? Or is it 10 to 11 years? Just think of an answer in your mind. Now, just try to remember. As per your cursory recall, what is the average age of children presenting to you with childhood menarche? Is it 8 to 9 years, 9 to 10 years, 10 to 11 years, or 11 to 12 years, or 12 to 13 years? Now, there has been an epidemiological shift in the recent years. While the previous generation in India experienced menarche at 13 to 15 years, recent studies indicate a secular trend towards early pubertal onset. And the large-scale Indian study has found that the mean age of menarche is still 12 years and 4 months. It is not 9 years or 10 years. The median age of thelarche is still 10.8 years, pubarche is still 11 years, and menarche is still 12.1 years. So, distinguishing normal from pathological is important because menarche before 10 years in Indian girls cannot be considered a normal variant. The third percentile for age at menarche in Indian urban girls is 10 years and 2 months. So here you see it's a continuum. All girls would not have their periods at the same age. The average is around 12.5 years. But any girl having periods less than 10 years, 2 months is definitely needs to be treated. And between the age group of 10 years, 2 months and 12.6 years is the gray zone where it is a case-by-case decision or whether treatment is required or not. So as you see, the average age of 12 to 13 years is not the age of children who are visiting your OPD. Why would somebody who has periods at 12 years visit a gynecologist or a pediatrician or a pediatric endocrinologist? Because it's normal. Those who are visiting us are having it early. Because the numbers are increasing, we have started to think that it is normal. But that is the classic case of Bergsonian bias. It's referral bias, which occurs when a sample of patients seen in a healthcare setting is not representative of the general population or the true prevalence of a condition. It's a reminder that patterns we observe in selected groups may not represent reality in the general population. For example, you could think that most cars are white because you're looking only at the white cars in the parking lot. But when you see the entire parking lot, you would see that cars are of many different colors, especially those who are not in the parking lot. So it's a classic case of referral bias. This bias can lead to several issues. Overestimation of the prevalence of early puberty in the general population. A lot of parents are told that it's normal. आजकल तो 8-9 साल के बच्चों को डेट आ जाती है. That is a wrong advice. If we fall prey to this bias, we have a tendency to normalize it and a misunderstanding of what constitutes normal in the broader community. Potential misdiagnosis or delayed diagnosis of this less common presentation. The greatest benefit lies in picking these children up early. And the international accepted definition by convention to detect precocious puberty is breast stage standard 2 less than 8 years in a girl, pubic hair stage 2 less than 8 years in a girl, menarche less than 9.5 years. This definition for Asians is 10.5 years as per as the Japanese guidelines. Early puberty itself may be a symptom. It's a manifestation of underlying disease. That's very important to remember. What is puberty? Simple terms. It's the manifestation of hormonization of a naive child's body. If it is happening early, the hormone may not be coming from where it should, which is known as peripheral precocious puberty. When you see, when we talk about peripheral puberty, before we go into the garden variety, typical classical central precocious puberty, we should look at the differentials that are there in front of you, so that if any of the supporting signs are not there, you can straight away go towards approaching a case as a central precocious puberty. So the most important sorry for the glitch. So the most common differentials in peripheral puberty, which is not central puberty, are ovarian cyst, McCune-Albright syndrome, ovarian tumor, exogenous steroid intake, Cushing syndrome. And if you do not have all these presenting all the supporting evidence of these differentials, then you're looking at typical garden variety central precocious puberty. Hypothalamic hamartoma and intracranial space occupying lesion should always be kept in mind whenever you approach a child with early puberty. Now, why should we bother? What is at stake? First thing at stake is final adult height, because premature epiphyseal fusion causes short stature. Then emotional health is at stake, metabolic health is at stake, and there is malignancy risk. Now let us see what is the evidence. Talking about final adult height, these girls aren't just losing their childhood, they're losing precious inches from their adult height. Because the pubertal estrogen surge causes a rapid height spurt, which leads to premature epiphyseal closure. The child does not reach her genetic potential. Now, what is the matter if the child falls short of how tall he or she could have been? There are psychological issues. This child is a short child in a family of normal height or tall people. Then there are perception issues. We can deny it as much as possible, but the society does view height as a sign of, I would say, falsely placed sign of somebody being better or worse. Then there are marital issues. So when this girl is going to get married, somebody who's 4'9" or 4'10" can have issues when they grow up. This is known as the inverted pyramid of heightism in child psychology, wherein height can have a contributing factor in causing certain psychological issues in some children. Now, do all children with early puberty end up short? The answer is no. You would have seen many children who got periods early, but they reached a normal height. Is it possible to predict which child will lose out on final height? The answer is yes. And how we do it? We do it with the Bailey and Pinnu's technique of future height prediction based on an accurate bone age estimation from a simple hand X-ray. Now, the hand X-ray tells us the bone age of the child. This bone age, when put into the Bailey and Pinnu charts, gives us the predicted height at 16 to 18 years. So when we know that this child is likely to end up at this height, we can have an informed decision whether to treat this child or not to treat this child. Some girls with periods at 10 and a half, 11 years would have a predicted adult height, which is absolutely normal. In that situation, you can tell the parents that from the height perspective, this child is well placed. From the other things, you have to discuss with them. What are the other things? First thing is emotional health. Now, children who get early puberty become very tall suddenly, the tallest in their class, but their mental growth is their age appropriate. This is an intellectual physical discordance. This is the only child in her class who started to look like a grown-up girl. And that's why they look elder than their classmates. But the elder girls don't like to play with them, talk to them, because they're psychologically less mature than similar looking girls. Children like to befriend similar looking children. This is a conflict this child faces in classroom daily. The children who are psychologically as mature as her don't want to play with her because she looks like an older girl. The older girls don't want to play with her because she thinks like a younger girl. Now, and imagine the teasing, the confusion, the isolation. It's a recipe for depression and anxiety that can haunt these children for years to come. And we have definite evidence that it does. Early puberty is related to psychological distress, including depression and anxiety. Early menarche has been associated with an elevated risk of depression and an elevated risk of substance abuse, almost double. Now, simply talking about emotional health, just imagine this. A 10-year-old girl is in class 5, any earlier in class 4 or class 3. So she asks, Mama, is this blood? Why aren't we going to the doctor this time? It's difficult for a mother to rationalize with her why she is bleeding every 3 to 4 weeks, whereas many of her friends are not. And the mother asks you, Doc Saab, this is too early for her, isn't it? And you need to answer it, because the absolute hormonal roller coaster of mood swings, acne, body odor, all before they've outgrown their Barbie dolls, can be too much for a child to handle. And that's where a doctor's right advice comes in, whether this child needs treatment or does not need treatment. In addition, there is evidence that early puberty is related to hyperinsulinemia, coronary artery disease, diabetes, and premature menopause. Coming to malignant, and also it leads to, so when you subtract everything else, it leads to a higher all-cause mortality. Now, this is a very elegant follow-up, 37 years follow-up of 61,000 Norwegian women. And this is Scandinavian, so it's high-powered studies. 10% higher mortality in later life in those who had menarche at 10 or 11 years of age. Closer to us, this is Japanese study which shows a increased risk of all-cause mortality. Also, these associations were independent of lifestyle, anthropometry, and reproductive factors. So everything apart, early periods associated with higher risk of all-cause mortality. Similar findings have been shown in studies from Singapore and China in the recent times. Coming to malignancy risk, usually we don't even associate early puberty with malignancy, but there is evidence emerging which is linking both of them. So here you have a meta-analysis including more than 120,000 women with breast cancer from 117 epidemiological studies published in the Lancet. For every year younger the woman was at menarche, her relative risk of breast cancer increased by a factor of 1.050, which means breast cancer risk increases by 5% for each year earlier that menarche occurs. Women who had menarche at age 11 or younger had a 15% higher breast cancer risk compared to those who had menarche at age 13. The textbook Cancer Epidemiology and Prevention by Schottenfield and Fromini also states that early age at menarche is one of the most well-established risk factors for breast cancer. Talking about ovarian cancer, for menarche less than 12 years is associated with a 14% higher risk of ovarian cancer. The textbook Principle of Practice of Gynecology Oncology by Bagalkot also notes that early menarche is a risk factor for ovarian cancer. Endometrial cancer, menarche less than 12 years had 39% higher risk of endometrial cancer. This is an analysis of 30 studies. And the American Cancer Society's publication also states that early menarche is a known risk factor for endometrial cancer. So you have a 15% higher risk of breast cancer, 39% endometrial cancer, 14% ovarian cancer. It is no small number. This editorial very elegantly summarized everything, because the ones that I showed you previously are more recent. This was about 6 years back, published in Nature Reviews from the Cambridge, which said for every 1 year earlier than 12 years, a person goes through puberty, the chances of going on to develop breast cancer increase by 6%, endometrial cancer increase by 28%, and ovarian cancer increase by 8%. More work is still needed to understand the exact mechanisms involved, but the proposed mechanisms still now are a prolonged exposure to endogenous estrogens and progesterone throughout a woman's reproductive life, increased number of ovulatory cycles, which may increase DNA damage and replication errors in ovarian epithelial cells, alterations in hypothalamic pituitary gonadal axis, potentially affecting hormone levels and tissue sensitivity. Now, I think I have given you enough to think, enough to maybe convince you that we need to bother about early puberty. Now, what is the diagnostic pathway? The diagnostic pathway is clinical, labs, and imaging. So it consists of clinical, laboratory, and imaging pathway. Clinically, you have to look at the orderly progression from thelarchy to height spurt to menses. In the labs, the gonadotropins would be raised. LH is more than 0.2 MIU per ml, and the GnRH stimulation is positive and progressive. That means once you give a GnRH analog 0.1 milligrams of triptorelin, then the LH value should be more than 7. And your estrogen level after 24 hours should be more than the level at the baseline. Coming to imaging, the bone age is advanced. On ultrasound, the uterus should be more than 30 millimeters in length. Ovaries should be more than 1.5 ml in volume, and endometrial thickness should be more than 1 mm. Now remember this, as I said, thelarchy, growth spurt, and menses should be orderly. If you have it coming in any other combination, you are not looking at central precocious puberty. That means you're not looking at hypothalamic activation of the ovarian axis. You're looking at estrogen that is coming from somewhere else. In these situations, you can have any order of menses, thelarchy, and growth spurt. In these situations, the gonadotropins would be suppressed, GnRH stimulation would be negative, and a relatively higher sex steroid concentration. The bone age is advanced in these cases. Ultrasound uterus may be more or less than 30 mm, but importantly, the ovaries would be less than 1.5 ml, which is the normal case in most children. In children, any ovary size of more than 1.5 ml should be looked at with suspicion. Endometrial thickness may be more or less than 1 mm. The catch point in these children would be the ovary. Isolated premature menarche without other signs of pubertal development is rare and warrants an endocrine evaluation. There are children who would just have one cycle and not after that, but they would not have breast development, they would not have an advanced bone age. That is an entity which is very, very rare. So all children have to be investigated. Now coming to the treatment is quite simple. GnRH analog therapy has to be given. Why? We have to block the secretion of LH and FSH. You all know about it. GnRH analogs do it with a positive feedback, and to a gathering of gynecologists, we don't need to go into the detail of how they are working. What are the goals of treatment with this drug? We want to temporarily stop puberty, and we want to decrease the rate of bone maturation. How is the response? The response is evaluated with slowing down of the rapid growth spurt, and the pubertal stage of the child would either remain the same or possibly regress. There will be a slight agonist effect, so the LH estradiol would increase, and then after that, the hormone levels and the gonadotropins level would plateau down and stay there. Daily preparations are not used. The ones we used are depot preparations. The most commonly used are leuprolide and triptorelin. The doses are different. It could be every month or every 3 months. The most commonly used strengths are 11.25 milligrams every 3 months. The dose can be titrated as per the requirement to 2 to 3 monthly. Some people like to start with the 3.75 milligrams every month and then graduate to 11.25 every 2 to 3 monthly. Still, when do you continue it? You discontinue therapy when the chronological age is appropriate for the child to have menses. A skeletal age should show normal final height prediction. Growth rate. Some children would stop growing beyond a certain time, and if the growth is too slow, you can consider discontinuation of therapy. Then a very important is the psychological profile. The parents have to help in the decision making. It's a shared decision making whenever the child is ready. So the patient's and the family's desires are also important. The decision should be individualized. If emotional maturity or attained height is an issue, discontinuation can be earlier or later. So it's a very case-based discussion. So over the years, we've realized every family thinks differently. So enough space should be given to them to take a call on how long they want to continue the therapy. It has been shown in studies to be safe till 14 years of age. Nobody has studied after 14 years because there's no point of studying it. But in normal children, you can continue till 14, and you should at least continue till 11 years. Many parents would choose to continue till 11, 6, 12, sometimes till 12, 6. It's their choice. Long-term safety. Whenever we talk about GnRH analogs, a big question is asked about safety, especially whenever I talk to a gathering of gynecologists. Safety is a very big concern. Now, the long-term experience has shown these analogs to be effective and safe. Effectiveness depends on timely initiation and good titration of therapy. By titration, I mean some children would require a higher dose. They might need to go to 22.5 milligrams. And you can do it the other way also. You can make the injection frequency from 3 monthly to 2.5 or 2 monthly. So good titration of therapy makes it very, very effective. Gonadal function in both sexes treated with GnRH analogs is not different after cessation of therapy and completion of puberty than the general population. Bone mineral density. Everybody is worried about bone mineral density. During therapy, it may be slowed, but bone mass accumulation after cessation occurs similar to peers. Now, that is where the difference comes when you use the same therapy for treatment of endometriosis or infertility later in life, and you use the same therapy in children. After the age of 25 to 30 years, the human bone stops accruing calcium from the blood actively. So if during GnRH analog therapy, the bone mineral density goes down, it stays down. That's why it's related to osteoporosis in later life. But in children, the moment you stop the therapy, within weeks, the bone mineral density becomes normal because they are in that age group where their bone is actively accruing calcium from the blood. So they would not be subjected to osteoporosis or low BMD because of GnRH analog therapy. Hence, in children, there is no risk of osteoporosis in future if they are treated with GnRH analogs in treatment of precocious puberty. Still, the recommendation is to supplement these children throughout with vitamin D as an added hedge against bone mineral loss. The available evidence proves that adults who were treated with GnRH for CPP have normal fertility. In fact, they have enhanced fertility as compared to those who are not treated. So all the more reason to not deny treatment to these girls, because not treated, they would have lesser fertility, and treated, they would have enhanced fertility. Now, I would like to propose some conclusions and suggestions as I end my talk. The studies indicate that societal expectations based on historical norms may lead to underdiagnosis of CPP in the Indian context, and we need to avoid that. Increased awareness among healthcare providers is crucial for timely intervention because it's a rapidly evolving field and the age limits are no longer the ones that they were in the past. If you see a girl under 10 years with her period, don't just nod and reassure. Raise the alarm. And if you notice breast buds in any girl less than 8 years, that is not normal. That is a cry for help. If you have the slightest of suspicion, you need to investigate, or you need to treat, or you need to refer pronto. There's no point in waiting because these girls would lose out on final height faster than you would imagine. Amongst 10 to 11-year-olds, many may not need therapy, but many would if final height is compromised. So this is an age group where it has to be seen at case-by-case basis. Every month counts. The earlier we catch this, the better chance these girls have a normal life. And don't assume it's fine just because it's becoming more common. So I would like to end with this very famous saying that children have a limited time to grow, but a lifetime to live with the consequences. So please make sure they get timely puberty, because puberty is irreversible and the effects of this passage will stay with the child forever. Thank you very much.
Thank you so much, Dr. Saurabh. Saurabh sir has joined. Sreedevi ma'am, you may take over from here, and you
Yes,
can
ma'am.
all ask your questions.
Yes, ma'am. Very nice presentation, Dr. Saurabh. Does this Frisk hypothesis hold good any longer? That a person should achieve a particular body mass index like 14 to achieve menarche? Does it hold any longer?
See, the hypothesis stays, but it is not a universal hypothesis. Now, what we have learned, so the hypothesis was a very good point to start all the studies that have happened. And what we have realized is that BMI has a permissive effect on the activation of the hypothalamic ovarian axis. What does that mean? That means that if you are high on the BMI, then the activation would occur relatively early. That is why obesity has increased the prevalence of early puberty. So it sprouts from the same Frisk hypothesis. However, we look at it, we say it in a different way now, that your BMI and body weight will have a permissive effect in girls. So in boys, it's the other way around. But for girls, if you compare a normal BMI girl with a heavier girl, the heavier one has a chances of attaining menarche earlier.
Yeah. And one more thing I would like to bring to all your notice, that in Andhra Pradesh, I think it was during the COVID time, we had a girl who was menstruating, who had menstruated at the age of 6 years. And it came in the papers, and they had asked for crowdfunding, most probably for this leuprolide injections, saying that that child needs treatment for a long time and the treatment is costly. They happen to be poor patients, and they had asked for crowdfunding, and it had come in papers. So it was a 6-year-old child who had attained menarche.
Dr. Saurabh, choice between leuprolide and triptorelin.
Ma'am, it's just the two sides of Atlantic differing in their choices. So the Americans really like to use triptorelin more. The Europeans like to use leuprolide more. Clinically, effectiveness, there's not much difference. I have been fortunate to be trained under two teachers. One of them was fond of triptorelin and one of them was for leuprolide. And so I've seen this in my training and also in practice. They both work very fine. Just that some differences, there's a slightly increased weight gain in studies on children who have been on triptorelin. And second difference is the cost. Triptorelin is almost double in cost than leuprolide. Other than that, they both work very fine. There are not many companies in India who are manufacturing triptorelin, so most of it comes from Germany. And in many Indian companies are manufacturing leuprolide.
And how do we titrate the dose? As you said, titrate the dose. How do we do the titration?
Yes, that's very important. So when you initiate, it's a matter of choice whether you start with a monthly 3.75 and then you graduate the child to 11.25 after 3 months, or you start with 11.25. Both of the regimes have been shown to be no different clinically. The titration happens after that. Now, two things. First of all, we are targeting immediately. So we are looking at a child who's not started with her periods yet, who's presented to you with typical findings of precocious puberty. There, how would you analyze that the treatment is working fine? It is the growth speed of the child.
Because
Children in this age group, there is children in
Some
the
disturbance.
there is some. Can this person be muted? Okay. So, yeah. Children in the age group of 8 to 10 years who would typically be diagnosed with precocious puberty should grow at a speed of 0.5 centimeters per month. A girl who comes to you with precocious puberty is typically growing at 0.7 to 1.5 centimeters per month. So if you see the child every month and the growth speed is 0.5 centimeters, this means that the medicine is working fine. Any growth speed more than 0.5 centimeters, you have to make the injection, which was scheduled to be a 3-monthly one, to a 2-monthly one. Secondly, in girls who are heavier than 30 kilos, there are now some European studies which say you should start at a higher dose. Either you start at 22.5 every 3 months, or you make 11.25 every 8 to 10 weeks in those girls. So that's how we titrate. Now, over the years, there have been some children in our practice who have just not responded to 11.25. Their growth speeds might have come down, but they continue having their monthly or 1.5 monthly bleeds. Now, that's a very tricky situation because, and on ultrasound also, they are developing endometrium over and over again. Their hormone profile shows good suppression. So in those situations, we have been successful in controlling it by switching them to 22.5 milligrams. So, but that is a very small subgroup. Hardly 2% or 3% of girls would require. Most of them would respond to either a 2-monthly or a 3-monthly 11.25 injection.
Thank you. Are these children more prone for premature ovarian failure?
Not failure in the true sense of the word, but
insufficiency.
Insufficiency. Yeah. So failure would be very different.
Insufficiency.
Yeah. So they would run out of their ovarian reserve earlier, but that would not be in their early reproductive phase, but it would be later because of the nature of the ovary, wherein you have the fixed number of follicles. So they would run out of them earlier because they start with their periods about 4 years earlier. Yeah.
So any lab parameters which you would say, like the level of estrogen to titrate and to stop the treatment, lab parameters?
Ma'am, on treatment, the estrogen would be suppressed anyway. So there's no point in getting the parameters done once the child is on leuprolide therapy. The only indication of getting blood tests done for a child who's on therapy is if we want to document suppression. So you have to, and that's also one more, as Dr. Bhargav was asking about titration, ma'am, this is also one thing that we do in titration. Before we change the frequency, to be sure that the injection is not working properly or the dose has to be changed, we need to get the LH level 1 hour after the injection. As I said in my talk, it's an agonist. So once you give the injection, it will have the agonist effect. So if the child's axis is not suppressed, the LH should shoot up. So if the LH in that situation is less than 5 micro IU per ml, then you can assume that it is well suppressed. And Dr. Mahesh, we do not need to see any levels when we have to stop the therapy. The reason is that the point of stoppage would be determined clinically. 1, the child's age is appropriate. 2nd, the parents are very happy with the height the child is attaining. The X-ray shows that once we stop therapy, the child is still going to grow these many inches and the final predicted height is going to be normal. And the child is psychologically ready to attain that level where she's okay with those, with all the pubertal changes. So you don't need to do estrogen at all. During therapy or at cessation, you don't need to do estrogen.
Thank you so much.
So that height predicting chart, do you mind putting it in the group?
Yeah, the belly and pinnu chart. I'll put it. Yeah. I'll take the photograph and put it in the chart. Yeah.
Thank you so much.
Yeah.
It's a calculator, I think, right?
No, it's not a calculator. It was designed by British long back. So it is actually a calculation as to what proportion, what of the final height is attained at what bone age. So you just have to join the two lines and you get the prediction.
Okay, and what is the accuracy?
So plus minus 2 inches. And
That's a lot.
in fact, what I've seen in practice is for children whose parents are short, it is minus 1 inch. And for children whose parents are tall, it's quite accurate because it was designed for Caucasians. And we are using a Caucasian chart for Asian children. So that's where the spread comes in. So they don't say it is plus minus 2 inches. It is what our teachers have been using and we've been using, that we've come out with these plus minus 2 inches. Yeah.
I think now it's time for you all to get together and design your own.
Definitely. And I think the day would not be very far.
Yeah, with so much of make in India.
Yeah, definitely.
Dr. Saurabh, any adverse effects with the GnRH analogs? Have you ever seen any adverse effects with it?
Ma'am, sterile abscess is not very uncommon. 1 in 20 children develops it because of the depot injection. So 1 in 100 children would develop infection in that sterile abscess, but that responds quite normally to simple antibiotics for 3 days. Other than that, there's no adverse event we have ever come across. So that's it. And sterile abscess, some children would just have 1 abscess in their 2 or 3 years of therapy. But there are 2 children that I have who've had it repeatedly. And usually once you switch brands, it resolves. But that one child always is on my mind because she's developing it with any brand that I've used.
So could it be
do you have any?
It could be some sort of allergy, right?
Ma'am, allergy, it's difficult to say that. There are no other signs clinically of an allergy, and sterile abscess is a documented adverse effect of these depot injections.
So do you have any issues with compliance, Dr. Saurabh? Because children getting dose every 3 months or 1 month, do you have issues with compliance?
Ma'am, it is by the grace of God, no. By the grace of God, no. And usually, so what we actually try to do is, see, because we deal with children, so maybe it's the way we practice. We try to make the injection environment very, very friendly for the child. So it starts from the moment the child walks in, the staff knows the child has come for an injection. So the entire journey, we try to make it as less painful as possible. So it has succeeded till now, but by grace of God, till now, there's not a compliance issue.
Nice.
Sir, after stopping injections, would you like to see her later on, and how long you want to?
Okay, that's a very important question. So after we stop the injection, what is the expected natural history in that child? So 4 to 6 months after the last injection, you would see the signs of puberty coming back. So if you had started injections at, say, for example, stage 3, B3, so the child would start progressing from B3 onwards 4 to 6 months after you stop injections. The expected date of menarche would be 6 to 18 months from the stoppage of injections. And the child would continue to grow because we typically stop the injections at a bone age of around 12 years. So they would have a good 1.5 years of growth left. So we like to see them every 3 to 4 months and telling them that this is the expected timeline, what is going to happen. One very important point to reinforce in these children, especially in today's time, is to guard against obesity. Why is this so? Because one, the prevalence of obesity is increasing. Anyway, we have to guide all children to stay away from all those things. But these children need more emphasis because precocious puberty is a very has a very strong association with polycystic ovarian disease in later life. Number one, obesity per se is strongly associated with adolescent hyperandrogenism and development of PCOD. So these two things coming together can have a double whammy effect. Secondly, SGA children who are small at birth, are more prone to precocious puberty And SGA children are more prone to obesity at older life. So you join all three things. Somebody who was born SGA, had precocious puberty and develops obesity, there's very little to protect her from the risk that she's carrying of polycystic ovary disease. And to this gathering, I don't need to reinforce it's such a major problem. So we need to in the 4-monthly counseling, it has to be again. And once you stop therapy, once the estrogen starts coming, naturally all girls would have a tendency of gain little weight. So, and this coincides with the adolescent age group where they're not listening to their parents, where they have their teenage groups, where they have their newfound freedom and with deliveries and everything. So follow-ups are very important even after we stop therapy. So thank you for bringing that up. It was something that I missed during my talk.
So there's one more question. It's in the chat box on YouTube by Dr. Archana Rokade. What is the role of growth hormone in treatment or pathology?
Okay, very, very good question. And first of all, in pathology, there's no role of growth hormone. In treatment, growth hormone is now an FDA-approved therapy to be combined with GnRH analogs in those girls who are ending up very short. Number one. Second, FDA-approved therapy, you add growth hormone if the girl develops the signs of precocious puberty before the height of 130 centimeters and the child was born less than 2.5 kilos. I'll repeat it when I summarize it. Third thing, some girls on treatment would have a slowing of growth speed and would plateau. They would not be growing because some levels of estrogen are required for bone growth. Sometimes they will not be growing. So that is the third indication of adding growth hormone to these girls. So I would summarize. Number one, child was born SGA, develops precocious puberty and height is less than 130 centimeters. You need to add growth hormone. That is the GRS guidelines. Second, predicted height is really low. That situation also you need to add GH with GnRH. And third situation is plateauing growth velocity while the child is very short on GnRH analogs. But mind you, these indication would be less than 10% of all the children who visit you for precocious puberty. 90% of them would not require any growth hormone. And in 90% of them, their predicted height continuously increases over the years once you keep them on therapy.
Thank you so much, sir. Sreedevi ma'am, would you like to say anything before we go to the next session?
Yes, that was a very good presentation, Dr. Saurabh. Very nice. And most importantly, the research that they're more prone for cancer, all sorts of cancer, ovarian, endometrial, and breast cancer in later life is really something that needs to be taken care of. Very nice presentation. Thank you so much.
Thank you.
So thank you, Dr. Saurabh. Thank you, Sri ma'am. We would love to have you present in the panel as well if possible. We have one endocrinologist with us as an expert for the panel as well. So, Shri Ganeshaya Namah, that's my guru, asking us all to proceed to excellence in whatever we do, whenever we are, whatever we are. Big undertakings begin in a small way. So I would like to introduce my panelists. We have Dr. Kartheek Nalluri, who's an MD Pediatrics from Amrita, Kochi. He's a fellow of Pediatric Endocrinology, ICMR training in clinical genetics, consultant pediatric and adolescent endocrinologist. Has the Children's Clinic for Growth, Diabetes, Thyroid, and Hormonal Problems at Vijayawada, Guntur, and Bhimavaram. Welcome, Dr. Kartheek. We have Dr. Ruche ma'am, who suggested the idea of this webinar and also got me the beautiful speaker. Welcome, Dr. Ruche.
Thank you.
She is consultant and director at Bhargav Advanced Gynec Surgery Cancer Center. She's past secretary, Foxy Jalandhar, chairperson academics at Jalandhar Society, patron of the PCOS Society, and faculty at national and international conferences. There's a lot more which she hasn't said here, but when she starts speaking, everyone would understand. Then there's Dr. Somalatha Raparty. She's a consultant obstetrician and gynecologist at Bhargav Nursing Home, Vijayawada. She's done her MBBS from Guntur, is a credentialed IMS menopause practitioner, has special interest in endoscopy and high-risk pregnancy. She has been a faculty in various conferences. Welcome, Dr. Somalatha.
Thank you.
We have Dr. Jyothi Mahesh. She is from Kasturba Medical College, Mangalore. Consultant gynecologist at Mahesh Surgical and Maternity Center, Tumkur. FMAS World Laparoscopy Hospital, Delhi. SIM from IMS. Past secretary, Tumkur Obstetric Gynec Society. Past treasurer, IMA Tumkur. And a life member of IMA, Foxy IIG, IMS and ISAR. We have Dr. Annapurna Yella, another gynecologist who has been with me in many of my programs. She is an MS DNB FI surgery from Gandhi Medical College, Hyderabad, fellow in gynec endoscopy, robotic surgeon, professor and in charge HOD, runs the simulation course at GSL Medical College, Rajahmundry, founder member of Hysteroscopic Society of India, member endoscopy SIGIFS South Zone, past secretary Rajahmundry Society, has 40 plus publications. Welcome, Dr. Annapurna ma'am. We have Dr. Sanjita, another person who is from Raipur Society, a young, dynamic gynecologist, eager to be on my panel, and she's been with us more than once. She did her MBBS MS from Pandit JNM Medical College. She is SIM, trained in ultrasound and colposcopy, member of FROGS, RMS, ISOPAB and IFS, currently working at a 50-bedded government hospital in Raipur and also practicing at Hope Health Hospital, Mana. She's a winner of the gold medal of our society. Thesis paper has been published in an international journal. And welcome.
Thank you, ma'am.
So these are all the papers from which the questions have been put together. So it's a very basic question. What I would like to ask you, any of the panelists may answer my question. When do you define precocious puberty? What is precocious puberty?
Ma'am, if this is Dr. Jyothi Mahesh.
Yes, ma'am. Welcome.
Ma'am, if there is a philarchy before the age of 8 years or menarche before the age of 10 years, we call it as precocious puberty for girls.
Okay, actually, the mathematical answer is 2.5 standard deviations less than the mean. And the mean, sir has already told, is 12.6 years.
Ma'am, there's also, we need to also look at the pubic hair, presence of pubic hair before the age of 80 years, and Kartheek is also added in the definition, along with the thilarchy.
Yeah, actually, I didn't say thilarchy. I just said that any of those three, whether it's thilarchy or pubic arc or menarche, anything, 2.5 standard deviations before the mean. That is the definition. So, sir has added pubic hair to it. So, this is, I think, the initial question would come to you, Dr. Kartheek, that a 6-year-old girl presents with early breast development and pubic hair. Her mother had menarche at 9 years of age. So, what could be the cause? Is there genetics involved?
There Yeah, ma'am. There is definitely the genetics involved. Uh, we have two genes which are common, which is MKER and mm, the the uh, the ligand genes, which are commonly associated with early puberty. So these genes are associated with, in fact, very rapid progression of the puberty, which are the DLK1 and the MKRN3.
Okay.
And there's definitely a family history involved.
So here there is a family history. What are the other patterns that might suggest a genetic cause? Anpurna ma'am, would you like to take this?
Yes, ma'am. There are genetic patterns like either loss of function. Sir has told about this MKRN3 or DLF type 1 gene function, wherein they are supposed to suppress the GnRH activity, either that or gain of function, like the KISS peptide gene or the KISS peptide receptor gene. If there are any mutations for these two type of genes, probably the girl might have. And the predictor is also here in this case, even the mother is also having this earlier menarche. So definitely these two genetic predispositions should be evaluated in this child.
So Sanjita,
Yes,
if you do genetic testing,
yes,
does
ma'am.
it change the diagnosis and management?
Yes, ma'am. Because if genetic, we can we could identify the genetics in this case, then we could go for targeted treatment, ma'am. In this case,
What
and
targeted treatment can you go for?
and also, ma'am, we can counsel the other family members about this.
So
This thing.
counseling is fine. You've done the genetic testing. You got an
Yes, ma'am.
abnormality. Dr. Kartheek, does genetic testing benefit the diagnosis and management?
Yes, ma'am.
Or
So
it is academic in interest?
Mainly we can, if we do the genetic testing, we can identify them earlier, and then they can be kept under follow-up. So immediately when we see the signs, we can start management. So that is the main advantage of genetic testing. It doesn't change the course, but we can identify them earlier and start
So
management.
ideally, when that mother has come, is telling that I also had it early, that is something that she should have remembered first. Because now the young kid has already started breast development at 6 years. Ruchi ma'am, would you like to add something here?
Genetic testing helps us to rule out certain CNS causes of CPP. So that is one thing. And second is, if we do genetic testing, it is, I think, easier for us to counsel the future generations, the next of kin, not just the mother and the child, her sisters and their children ahead. So it gives us a early opportunity to intervene and counsel them.
Okay. So the girls who have the MKRN3 or DLK1 mutation, is puberty different for them, or the pattern is the same, only thing is it is accelerated?
Ma'am, actually the progression of puberty is very fast, those who have the mutation of these genes, ma'am, when compared to regular pubertal changes.
Okay.
They can I add something, Dr. Asha?
Yes, ma'am. Yes, ma'am.
They grow faster than a child who has achieved puberty in the normal way. As Dr. Saurabh was telling us about the rate of growth, so the speed of growth is more compared to a child who would grow normally with a normal puberty.
Okay. So, Dr. Somalatha, how are you going to counsel this patient and the family? Because here the family would need counseling.
Yeah, counseling is very important, ma'am. Family, parents, siblings, and other family members. We should tell them like reassurance is first thing, and what can be done for this young girl, and next what complications she can face. and what are the treatments available, and also for the next coming generations, like other siblings or other cousins or other family members, like sisters, daughters, or like something like that. So counseling is very important, both in psychological point of view and also medical point of view, like what can be done for her.
Okay, so Annapurna ma'am, what
Yes, ma'am.
lifestyle interventions do you want to add here other than the genetic management?
Yeah, yes, as sir was telling that because they are exposed to estrogen very early and high doses of estrogen, so they could have diseases like polycystic ovaries. Obesity also is very much associated with these precocious puberty, and even chronic disorders like diabetes mellitus, hypertension, cardiovascular disease.
So which-
So
this kid is 6 years old. So
no,
what
no, no.
lifestyle modification are you going to advise for her?
Her right now, actually, anyways, we are going to start GNRH analog therapy for her to attain or her height and all. And she should be counseled psychologically and to prevent obesity, I think.
Ruchi ma'am?
One point on counseling, ma'am, thing is ki as Dr. Saurabh said, people have started thinking it as normal. So we are not to normalize this precocious puberty. One. Number two, we have to make them aware that treatments are available and they are pretty safe. So they should go ahead with it, because the moment you talk of injections and hormonal injections, their parents, they withdraw. They are not happy with the idea of stopping this period that this child has had. So that is where counseling is very, very important, that we have to tell them that it's not normal. It's going to have her say on her health later in life. And the treatment that are available today are time tested. They are very safe and they should go ahead with them. As far as lifestyle intervention is concerned, she's a small child. So it's actually the family which has to be with her, and you don't get junk inside your house and the child will not have junk. So you have to be with the child in these trying circumstances. How much would a 9-year-old child understand about cardiovascular disease and everything in later life? It's what food habits you incorporate in your house, and that should follow, so that child does not land up in obesity, because we know it has a strong connection with that. So it's basically how we support her as a family rather than individually counsel a 9-year-old child.
6-year-old. She's 6 years
6
old.
years.
You want her to
6
play,
years.
right?
Sorry, 6-year-old, right?
You're going
They
to
should
ask
be-
her to play.
Yeah, they should be very physically active, ma'am. So we should tell them that they need to maintain a good physical activity so that it'll
That's
prevent
what.
obesity
She
in
needs to
future.
go out to play regularly. She has to play physically, run about, because that is how calcium is going to get into her bones and all the osteoclastic activity can go on. So, Dr. Kartheek, before I go on to the next case, I would like you to please give any additional points that might have been missed.
Ma'am, we have almost covered everything. So we need to, as ma'am has said and Dr. Saurabh has said, so that it is not normal to achieve, to get breast development at this age. So it is abnormal, and we have very good treatment options. So I think we have covered everything.
Okay, so now my question to all the gynecologists, you're going to treat her yourself or you're sending her to an endocrinologist?
I will be sending to endocrinologist.
I also, ma'am, would like to send an
Right.
endocrinologist where treatment will be better.
Yes,
Because, madam,
they
we
need
have
a
to-
holistic approach.
Because we
Endocrinologist,
have-
psychologist, pediatrician.
We need to
Ma'am,
monitor her
I-
growth also, so which we will not be able to do as gynecologists. So she needs to be under the supervision of a pediatric endocrinologist.
Ma'am, I would like to involve a child psychologist and endocrinologist and the gynecologist. All of us have to take a call.
Ma'am, if you are in an institute where all three are available, that is fine. But
Fine.
if you run a standalone practice, how are you going to get three different people for which the patient has to pay, right?
Yes.
And also sometimes I get scared to go also.
Sometimes they get scared as well. So the basic thing is how well we are going to counsel our patient. Because the treatment, she's 6 years old. She has 6 years of treatment ahead of her. So to educate about the cost, the effect of the treatment and the effect of non-treatment.
Non-treatment.
I think everything has to be actually explained multiple times before we refer. So that it is reinforced.
Dr. Saurabh wants to talk something.
Yes, Dr. Saurabh?
Because we are talking about the psychologist here, I would like to share something. Usually, when you start therapy in these girls, the parents would themselves come and tell you that the child has become psychologically so much better. There is a very significant reward. The child again. The child becomes a child again. So while the child is on therapy maybe for 2 years or 3 years, they are least bothered. And once in 3 months, they are walking in, they are happy, scared for 5 minutes, taken the injection, go back and everything is the same. So usually they do not have, if they are treated, they do not have long-term psychological effects and even short-term psychological effects. So you just being soft with the child and making the experience good enough is enough. You don't need to involve a psychologist in the treatment. However, a child who comes to you at 13 years, who was not treated and is coming with all the problems associated with it, problems of irregular cycles and everything with psychological effects, there you need, anyway, you will need to refer them to a psychologist there. So.
Okay. So there you are, Dr. Jyothi. Dr. Uppal, are you going to be around?
Yes, ma'am. Tell me, ma'am.
Tell me, ma'am.
No.
Ma'am, actually, we go to school for teenage from 5th standard to 8th standard kids. We teach about pubertal changes. Even when we discuss, many they don't open up. They hesitate so much. So even at every school, nowadays, with child psychologist and gynecologist, every year we are going and giving talks about pubertal changes and all. And what is normal, what is the normal onset, what is the late onset and all. So it has become a routine in our place, ma'am, actually. That's why I told
So that is good. If you are able to do it, there's no harm. It's only that, most of the time, all three together are not easy to get.
Yes. First, initially, we have to do the first counseling, and that should be the best counseling.
So now this is a 7-year-old who's getting breasts and having menstruation. This question is all about psychology. So what is the challenge faced by this girl? She's 7. That means she is in class 3 or class 2 maybe. A 6-year-old gets into class 1. So she's just entered class 3. What are the psychosocial challenges that she's going to face?
Dr. Saurabh explained this beautifully actually in his slides.
Yes.
She is a small
let
child.
us just recap it for those who have joined the program late.
So she is a small child. She is looking bigger for her colleagues and for her peers who are looking at the same height and all. She is psychologically not fit to play with them or mingle with them. And not only that, she is even if she's menstruating, then she doesn't have the capacity and hygienic. Even she cannot change the pads and all by herself. She has a lot of anxiety and even behavioral changes also she might have. So it is very difficult for her to cope up and fit in that environment, I think. So she might have many changes, body image. Everybody will be bullying her probably.
So,
she will be facing a
this
lot.
body is growing fast. So does the mind grow as well?
That's
Sometimes
what
they
Dr. Saurabh
think
said.
mature, ma'am. Sometimes some kids think mature.
But 7 years is too early.
As we said, there is a discordancy between the growth of the child, the physical and the mental growth of the child. As Dr. Saurabh had explained, that she is growing fast, so she looks like the elder girls, but her mental makeup is not like the elder girls. So the elder girls don't want to give her company because her maturity level is not like that. And the younger ones are afraid probably because she's taller than them. So she's in kind of an isolation. She's not fitting into either of the group. And plus, as we talk, if she's having menarche, she's losing blood. So the anemia is also having an impact on her. While the other children may be playing and running about, this girl is feeling physically tired. And the whole concept of losing blood, that in a 7-year-old child, it's very difficult to put it across.
Yeah. So what role do we have to play? The mother has brought her to us and she's 7 years old and she's menstruating. What is our role?
I think we should again put her with a holistic approach with endocrinologist, a psychologist, child psychologist, and even the total mother and child and the family should be counseled together, I think, for her to have a better
The first thing is to understand that it's not normal.
Yeah, even parents get scared first rather than the kids. Like telling them this happens and there is a treatment for this, so that this can be addressed is very important.
So,
Dr. Asha, I would like to share something here.
Yes, ma'am.
Since myself and Dr. Saurabh, we are from the same city, so we have a cross share of patients, these kind of patients. And I wouldn't remember the name of the patient today, Saurabh, but this girl, she was sent to you for precocious puberty, and her height never used to increase. And whenever I saw her, I used to find her of the same height. And today she had come with her Masi for delivery. So when I saw that girl, her mother told me she's the same girl who never increased in height. And you had referred to her to Dr. Saurabh, and now look at her. And it was such a pleasure looking at that 12-year-old girl today, that once she was into precocious puberty and today at 12 years, she has gained the height. I mean, it was just a pleasure. It was such a coincidence that I just happened to see her today. So if you counsel and you are able to get your message across that there is no harm, please get the treatment done. It will do the child a lot of benefit. I think the results are wondrous.
So, when are we going to prioritize treatment? Means actual medication compared to just counseling. This question is all about behavioral and psychological changes. So when do you want her to get psychiatric treatment?
If she is expressing any anxiety, depression, or shyness and not getting involved in any school sports activities, and she has any issues with the friends and all, then we have to involve the psychologist. First, we have to do counseling. And because suddenly if we tell them to go for psychologist or psychiatrist, they will never come back. So we have to do repeated counseling. Then we have to add on psychologist here.
So you add a psychologist, a psychiatrist, if you see any sign of hallucination, depression, suicidal thoughts, that is when you cannot delay.
Yes.
Right?
Yes, yes.
Other than that, you can counsel and proceed. So, Dr. Kartheek, are you still there?
Yes, ma'am.
So in this case now, would you like to add something before I go to the next?
Ma'am, it's just we need to sit with the child and the family and do a proper counseling. I think that will reduce the stress levels.
Sir, what would be the content of that counseling? Saying counseling is fine, but what is the content of that counseling?
Ma'am, in my practice, I just sit with them, explain the normal puberty, tell them it has been deranged, so we need to bring it back to normal. That's what we do with the help of medications. And the child can be a child again. So we stop the puberty at the point where we are intervening, and it progresses. I mean, it doesn't progress further if they are on proper medication. So timely, they need to come on time, and the child will lead a normal life.
The changes that have already occurred, do they reverse?
Not fully, ma'am. They might
It's like
regress
the breast
slightly.
development, the pubic hair, does it go back to prepubertal levels?
No, ma'am. They might regress slightly, but they may not go back to the prepubertal levels. If we catch them early, B2 might be, but I think beyond that, I think they may not regress fully. Like Saurabh can
Madam,
add to it.
if I can add, actually
Yes,
these
please.
girls usually they have tendency to overeat or undereat because they think they are too large for their peers. They might not eat properly, or sometimes they might eat too much with depression, and also sa- behavioral therapy also is very important. Eating habits, sleeping habits, playing, all this also should be incorporated into their thinking and their daily life schedule also. They should have a balanced diet. Uh,
Yeah, that is a very important point because anorexia nervosa, bullosa, all of that is also part of the psychiatric abnormality. So now we have been talking so much of obesity, and now you get an obese girl. She's 8 years old and she has a BMI at the 98th percentile. She has advanced bone age and thilarchy. So what role does obesity have to play? How does it contribute to early onset of puberty?
More adipose tissue means more leptin and more insulin level that can accelerate the pubertal onset, ma'am. It is more pronounced in girls than in boys.
It stimulates the axis, HPO axis.
HPX.
The HPO axis is completely almost altered and leads to early menarche or pinarche.
Dr. Karthik, I have to come back to you. What is the mechanism by which obesity leads to early pubertal onset?
Like ma'am has said, with obesity, there's a lot of hormonal increase. So we have this insulin increase, so which might lead to the early activation of the axis. There is leptin, which increases, and there's peripheral estrogen secretion from the obesity, which the fat. So it's due to sorry.
So
It's due to the hormone.
in this patient, would you want to take her insulin levels and her estrogen levels? Or you would just take her to treatment? Dr. Saurabh said you don't have to measure estrogen. You don't have to measure
Not
anything else.
Can I add something, Dr. Asha?
Yes, ma'am.
Because as we said, because of obesity, the insulin resistance is high in these patients. And because of that, the free sex hormones are high. And they are in some way linked to this precocious puberty. The leptin levels are increased, but the adiponectin levels are reduced. So they are in a way linked to this. This is how obesity is linked to precocious puberty.
Okay.
One more thing, madam, we have, because she's an obese girl with precocious puberty, we have to rule out the other syndromes like Cushing syndrome, Macron-Albright syndrome. Actually, we have to look at her as a whole person and look out for the syndromes. And if we find anything, probably we can treat her quite easily.
Okay. That is correct, that you have to not just think it is precocious puberty and not look at anything else. Does thyroid have any role to play?
Yes, ma'am.
Yes, primary hypothyroidism.
Hypothyroidism.
So now if she is obese and she is getting central precocious puberty because her HPO axis is disturbed, then what are the long-term risks and what are the short-term risks?
Yeah, here. So short-term risks, like I have to tell regarding a case, ma'am, where she is just 9.5 years old, and repeatedly she used to come with cyclical pain. So, like a little bit of thelarchy is there, but she didn't attain menarche. Every time she used to come with pain, just we have gone for a scan, and routine scan, and it is like typical PCOD, like we see at 18 years or 19 years. So definitely, this cyclical pain I have seen in 1 or 2 cases, and long-term risks are like they can have in future PCOD related menstrual problems and diabetes risk, metabolic syndromes, risk of hypertension, cardiovascular. All these we have to explain in detail so that at least the parents take some modes like how she can lose her weight. Very important and crucial time that she loses her weight so that next 10 years of life would be better.
Okay. So do you want to give her something to lose her weight, or you are going to, Dr. Karthik, this is for you. Are you going to keep her on Leuprolide or something and then give her something to lose her weight, or you want her to physically lose weight by diet and exercise?
Ma'am, these are two different lines. So if the child is in precocious puberty and it is central in onset, then the child needs to be on the GnRH analog. For the weight concept, we consider because it is adding on to the metabolic syndrome, hypertension, and
So her
everything.
BMI is at the 98th percentile. So what are you going to, you're going to give her some medicine to get thin, or you want lifestyle changes?
Initially, it's the lifestyle changes, ma'am, because the child is just 80-year-old. So we count in on the diet and the physical activity. Along with the Leuprolide for the precaution.
And there is no compliance. Now,
for the obesity part.
For the obesity, there is compliance. They are willing to take the injections. They are very well off, and they just want ab bolo. She goes to this class, she goes to that class, she goes to tuition. She has no time for exercise.
Ma'am, we have to see for insulin resistance, ma'am. If it is there, we can add metformin, ma'am.
In an 8-year-old?
8-year-old.
Madam, I think we should emphasize enough to the parent that this is the most important thing in her life at this point of time, not the other classes, because her future and present health lies on this, and make it the center point of her attention now, and try to do the best, because even a little weight reduction also will go on a long way.
Yeah, because she will put on height, right? So if she maintains the same weight, her height will increase and the percentile will go down.
Yeah, ma'am, we even... Sorry.
Yes.
Ma'am,
First Dr. Karthik, then Dr. Annapurna.
Yeah, sorry. Ma'am, I even tell them that if they increase in weight, the duration between the two shots will come down, or they need to go to the bigger shot. So if it is 3 months, then as the weight increases, so the drug wears off faster, or we need to go for the higher dose. So they might need to get it at 2 months. So that fear might help. In my practice, it will help them, because being an 80-year-old, if slightly bigger, then we can start on certain medication. But normally at 80-year-old, so I counsel on exercise and diet.
Okay. Annapurna ma'am, you were saying something?
Somebody else was speaking.
Ma'am, actually, it is Jyothi ma'am. Ma'am,
Yes,
actually, I call them at shorter intervals because she's 8-year-old. We can't just advise weight reduction, diet, and all. So I give them small, short duration of work. Like you have to complete this. This date I have written your weight, and you have to do these activities and come back after 1 month. So short intervals, I would like to improve her confidence. And that will give result for lifestyle modification. Definitely, even for PCOS, it works out. If we tell just diet and exercise, they will not follow, ma'am. So
yes,
short
you are saying to break it down, and be more specific.
Yes.
So in what percentage of cases does that work for you?
Ma'am, majority of the time, either they will be static or they lose the weight, ma'am. Majority around 90%. Only thing, I have to boost up their confidence. I should not bully them like you are obese, you have to walk, you should not eat like that. If I tell, they don't come back. We should not insult them. You should encourage the words, how you speak, they take it seriously. And it should be in a positive way.
Okay.
Correct, madam. Even I have seen that the mothers will tell she doesn't eat anything, but too she
Yes,
gains
madam.
weight. It is not only about the diet, it is about the short-term goals and long-term goals, what I tell the parent and the child. I ask them to keep short-term goals like a trip or a good dress, or I tell her to imagine a good situation. So most of the time they do decrease weight, but it is a continuous process. It is not a one point of time. Most of the time they do
Now,
reduce.
if she has lost weight, how does it benefit her precocious puberty? Does it benefit? And if it benefits, how does it do it?
Definitely, yes, madam. She would require, as sir told, she would require less frequent dosage of hormones, and it will benefit her health in the future also. And even any insulin resistance, any PCOS also could be prevented for the future.
So now we come to the socioeconomic factors. Girls are obese. Does the socioeconomic factor impact the prevalence of precocious puberty? Those who are from a higher income group, are they more prone? Or those from a lower income group, are they more prone? Or it is independent of the socioeconomic status?
It's generally said that the girls from the low socioeconomic families, they are more prone to obesity. And if they become more prone to obesity, then they cannot afford the treatment also.
Here it's the
Now,
question
here
of
is a,
balance.
yes.
You said that those from the low group are more obese, right? That's what you said. Dr. Annapurna, ma'am?
Yes, ma'am. Yes, ma'am.
So-
See, I'm actually split on this question.
Yes,
Yeah,
that's what I was.
actually-
There's a jack in this question that I think it is both the low and the high.
And as
High
well as,
because
yes,
they
ma'am.
have stopped working and they are more prone to junk food. They are more exposed to junk food and lack of exercise.
Pampered, yes.
Yes. Go on, please, Dr. Annapurna.
Jyothi?
Those with high socioeconomic status, like it all depends, ma'am. Some they eat balanced diet.
Means
The
if you
parents
have
are so
10
educated.
obese patients with CPP, how many would come from the higher income group? How many would come from the lower income group? Simple.
Many are from low income group.
But nowadays, 8 years, if we see, generally we are seeing of higher income group only more.
Yes.
Education
Okay,
of
so
mother
now
is
we
more
have
important.
two pediatric endocrinologists. What is your experience, Dr. Kartheek?
Ma'am, I've seen because recently now the food is available among both the socioeconomic status. So they're more attached to the junk foods. Initially, they used to be available only in the bigger packets. Now we have the smaller cool drinks, smaller. So they drink cool drink every day. So the obesity I'm seeing in both the socioeconomic status.
But CPP in central precocious puberty, you see more in the low or high?
Probably the lower, it's not that I see each group has a different, I mean, one is big, one is small, but I see the lower social, they might present later. So they might come at the later stage while the drug because of the cost. But I don't find any difference in the prevalence, I mean,
Okay.
in my practice.
So now, what preventive measures can be taken to reduce the dual burden of obesity and CPP? What are the preventive measures all of us can take? So we go fast about this because we have more cases.
Ma'am, public health awareness, especially in schools, including we should involve the teachers as well. So that is the first thing we have to do.
Somalatha, ma'am?
Lifestyle modification, ma'am, and encouraging the kids for sports as well. At least some hours of the day in the school or even outside. That is more important, ma'am, which is lacking nowadays. It will definitely decrease both burden of obesity and difficulties.
Okay.
And other lifestyle modifications, like eating a healthy diet, low calorie diet, and seeing that they get enough nutritious diet.
Okay,
Need
what
to
Ruchi
start
ma'am
teaching
said, no
the
junk at home.
Yeah.
Healthy plate concept should be introduced in schools, ma'am. So what they're eating, they should start eating more amount of fiber.
I think
because
the
if
school
that is-
canteens, they should stop selling junk food. They should be
Exactly.
selling healthy food, number
No
one.
junk in the school canteens. No junk.
And
And
for
no
that,
junk outside the school gate as well.
yes, and every patient that walks into your OPD, madam, just to keep the child quiet, they have given him or her a small packet of chips. Whether the child is 3-year-old or the mother wants the child to keep quiet, and that is the
So
easiest
they
way.
hand a mobile and a packet of chips.
Chips. So we
Means
have to
I'll tell you-
educate the mother first that she is not supposed to do these things. This is going to, always tell her, you give this child a packet of peanuts. Why did you buy this packet of chips? You could have given him some peanuts. That would
They
at least
don't
do
eat.
some good rather than. No, but it's because the mother, she finds it easily available, as Dr. Kartheek said, smaller packets, easy access, smaller cold drinks. So they are ready to spend money. At least the child will not disturb her. So this is her way of keeping the child quiet. So mothers have to be trained that this is not the way. We have to correct ourselves.
So basically, we need to train the mothers when they are getting pregnant.
Yes, absolutely.
That they have to take healthy diet. They have to not live off cold drinks and caffeine and junk, because that is creating that demand in their fetus. When it gets born, now it's proved epigenetics that they have all those cravings as well. So we start, mothers come to us when they are pregnant. So we start there. That is what I think, that is the one intervention we can have. Now, there's a lot of hullabaloo about environmental exposure. There's a 6.5-year-old girl adopted internationally, and she presents with premature thilarchy. Her parents mention frequent use of cosmetics containing parabens. So how do endocrine disrupting chemicals like parabens trigger CPP? How do they do it?
Ma'am, she is internationally adopted. So paraben containing shampoos and cosmetics and other chemicals also like bisphenol, etc. Is available easily there. It mimics estrogen. So it can cause disruption of normal functioning of hypothalamic pituitary gonadal axis, and it can accelerate the pubertal onset, ma'am.
So, if they are internationally adopted, like usually they are adopted from Africa. These days, adoption from India has become less because India now has introduced stricter laws. Previously, even from India, they used to be adopted and the white skinned people used to take them. So why are such girls more prone?
Probably exposed to more like endocrine disrupting chemicals and add-on stress, and sometimes nutritional factors as well.
Yeah.
Change in food habit, stress.
So what
change in
history are you going to take from this? About this girl has a lot of makeup, but what are the different things you're going to ask about in the history?
Ma'am, when she's not
Yes, Sanjita?
Ma'am, when she was not adopted, about history of malnutrition, we have to ask for, ma'am.
Okay. And?
Ma'am, history of plastic and personal.
What change she has got after adoption? We can ask them before how she used to be, how she used to get ready, and now what is the change she has.
So
she's
what are
using
the
now.
specific changes that make such girls more prone?
Ma'am, they might be getting the diet may change. Initially, maybe if she is adopted, probably she is from low economic status, and suddenly she is exposed to more like junk foods and all, and the makeup items like lipsticks, hair coloring agents. If parents are using, they are very inquisitive about them, and they start using even without the knowledge of their parents. They are at high risk, and the emotional disturbance which they go through because they are living in separate environment and now they are existing in different environment. That stress also can lead to this one, ma'am.
Yeah. So, what can we do about it? We as gynecologists, what can we do about it? What public health measures do you think should be taken so that this EDC exposure can be reduced?
What are the risks we are going to have in the girls because of these cosmetic products or EDC exposed chemicals? That should be educated by gynecologists and also public awareness. And also strict laws also. It's like something like there must be a limit for everything while using.
Plastics not to be reused, no reheating in plastic. These are basic things that, even we tend to do. You've stored something in the fridge and then you take it out and you are sometimes lazy and it is heated in the plastic. These are things that really should not be done. No reheating in plastic, single-use plastic to be discarded, makeup items mostly use only when required, and then you read the labels before you buy them. These are the basic things that we can all do, and this we can tell our patients when they are visiting us.
We can avoid certain food substances like soya, even it is normal. It has natural containing estrogens. And the cool drinks, from what I see, that is mainly linked to the obesity and early precocious puberty. The other thing is a lot of Pediasure usage, which they start using for the height, which is leading to a lot of obesity. Those people are also landing up in early puberty, ma'am. That's what I'm seeing in my practice.
So, would you repeat what you said last?
Pediasure, ma'am. So I'm using that, because they're using it for the height, thinking that they'll grow, but the obesity is growing in folds, not the height.
Yes, Pediasure. I have one girl in my family who, because of that Pediasure, which she was taking till 10 years of age, she had a BMI like she was 65 kg at 10 years of age. With all the problems and hormonal problems, and when she started menstruating, she would not stop.
Not only Pediasure, even milk also, adulterated milk. Also probably many cows and buffaloes who are giving.
I cannot say that because, most of the milk that today people are using is coming from the government. So now what is idiopathic central precocious puberty? How do you define idiopathic central precocious puberty?
Ma'am, when there are central precocious puberty is GnRH dependent, ma'am. And in that central precocious puberty can be because of some CNS abnormalities like hematoma and all, any space occupying lesions. If you have ruled out those causes, then it is called idiopathic.
Okay. So what are the hormonal markers that will confirm the diagnosis, Dr. Kartheek?
It's mainly the LH, the luteinizing hormone, which is important. So the increase in the the luteinizing hormone, if isolated sample, without stimulation, if it is more than 0.5, or the stimulated value after using tryptophan or leuprolide, So if it is more than 5, then we diagnose it as central precocious puberty.
Okay.
And
Now she
making
has
it
an advanced bone age. So why is early intervention critical? This lot is coming to you only,
Yeah.
Dr. Kartheek.
Yeah. So the bone age is advanced because the bone age advancement is due to the estrogen. So once the bone age is advanced, so we are losing the precious, like Saurabh has said, we are losing the precious height years. So the bone age advancement at 14 to 15 years, the height stops. That's when the epiphysis fuses with the bone. So if the bone is advanced, then so we need to intervene much earlier to protect the height.
Okay, so it is basically for height. So the treatments, what are the treatments? Are they different or they are the same? Leuprolide and...
There are the different versions of the GnRH analogs, ma'am. So in India, it's most available is leuprolide.
Okay. And how would you decide when to stop the treatment?
So depending, it mainly depends on has the child reached the adequate mid-parental height, and is the child psychologically ready to go through the changes, to advancement in the puberty. These are the two main things when we decide on stopping the GnRH analog.
So it's clinical.
Clinical.
So now, Anpurna ma'am, now I can see you for the first time. What role does monitoring play during treatment?
Yes, madam. We have to do the serial growth assessment. Sir was telling about some charts and he promised he would post it in the group. So serial growth assessment, we have to see how is her psychology, how is her behavior. And not only that, is she able to cope up with, is she able to adjust with her peers at this point of time? All that we have to see, and hormones also. We have to see, and then probably we can wean out of the GnRS therapy.
We have Indian Academy of Pediatric growth charts which are freely available. So we can plot the exact age of the child and the height. And we need to look at the mid-parental height, which is the father's height and the mother's height, average of the father's height plus mother's height. So we need to plot the child on the graph in every serial visit. And then we'll know if she's following the pattern. That is the first thing which we do in identifying that's what telling about the growth velocity. And
okay, Ruchi ma'am, before we go to
Yes,
the
ma'am.
last case, if you want to add something here.
No, this is, as Dr. Saurabh said, we really have to keep calling the child because we have to monitor the growth spurt, because we might have to increase or decrease the dose of GnRH that we are using. Apart from that, actually, child does not face any problems. It is always a pleasure to see such children, as he said, because the childlike innocence is coming back, or the childlike features come back. So they are very happy. So they are happy to visit the doctor. They are not the kind of children who are scared of visiting the doctor. So because the changes that were occurring, which were upsetting them, have now kind of stopped or slowed down. So they are happy to visit the doctor, and the doctor is happy to see them frequently because, well, increase or decrease the dose will depend upon the chart, how it is showing the speed of growth. Because the ultimate aim is that you want the child to achieve the height, expected height. So you cannot fail in that. So unless you keep a tab on that, the GNR, whatever the money is being spent on the injections, that should be fruitful. So you have to keep calling them. Not much of hormonal assessment is required. It's just these clinical testing of the child that is required to make an assessment whether whatever he or she dose is getting is fine.
So probably, as sir was telling, if we have to add any growth hormone, probably we can get an insight from the growth velocity charts.
So the last case, was again psychological, but it had basically 3 basic questions. What do you think is the role of schools in helping such children? Schools means not the classmates, but the school authorities, the teachers. What do you think should be their role?
Actually, because children spend more time in school than at home nowadays. They play very important role, ma'am. So education about puberty should be done from like school level only, so that they will know what are the normal changes when they have to approach the doctor, which is early, which is late, and also helping them to adjust with the peer group. The teachers play a very important role. So we have to first counsel the teachers and bring the program in their school routinely so that they adopt this education program every year. And they are counseled first, then they will help the kid to adjust to the changes.
So,
Physical
Ruchi
education is a must.
what is the role of the gynecologist? Annapurna ma'am, I'll come to you with what is the role of the psychiatrist. So, Ruchi ma'am?
Yes, the role of gynecologist is identification of the case at the earliest, counsel the family, especially the mother, that treatments are available and they should go for the treatment because it is going to help every way. It is going to help the child, psychological, physical health, mental health, risk of malignancy, as we said, in future life. So we have to encourage that this is now a treatment easily available, effective, safe.
Ma'am, one thing I want to say, and it's from the core of my heart, that we gynecologists most of the time have no time for counseling. Let us be truthful. Otherwise, today, why HPV vaccine is not being given? We see one dose of leuprolide it's more costly than the HPV vaccine. But we have failed to give it because we don't counsel. We don't have that time or the mental energy. So I think we as gynecologists, the first role is to educate ourselves. We hear of certain topics and there's a mental block. Ki ye to refer kar denge, kaam khatam. That should not actually happen. We need to be convinced ourselves that yes, there is a lot we can do. Because see, I have been trying to get awareness about HPV vaccine across for the since 2006 when it came up. Still doesn't work. Everything waits for the government, but here the government is not responsible. So we need to educate ourselves. We need to motivate ourselves first before we can motivate our patients.
Agreed.
And
Yes.
Puna, ma'am?
Yes, ma'am. Definitely, ma'am. You wanted me to tell about the counseling part of it. The child, not only the child, the whole family should be counseled. If the child is facing any specific problems, say her body image problems or eating disorders or bullying problems, those specific problems should be sought out, and uh, the whole family should be counseled along with the gynecologist, and a positive environment should be created for her to cope up with her physical stress also. And not only that, she should be, every time she should be reassured. She's still a child. So despite everything, she should enjoy childhood and live to her fullest potential.
Dr. Kartheek, would you like to add something before we proceed further?
Nothing, ma'am. Just identify early and start treatment early. So the child
So
will
I
lead
would
a
like
normal
to
life.
I thank all my panelists for a very, very interactive panel. Thank you, Saurabh, for setting the tone and almost putting everything together so that we can enjoy ourselves in this discussion. And all of you who are present here, I want one take-home point from each and every one before I end the session. So, Dr. Kartheek, because you're an endocrinologist, I'll come to you last. Okay? And I start with the youngest one, Sanjita. I start with you.
Yes, ma'am. Ma'am, gynecologists are usually first line of contact of patient with precocious puberty. And we can guide on managing precocious puberty through school education by telling them about family and mother's role and if needed, medical treatment, ma'am.
Okay. Dr. Jyothi?
Ma'am, take-home message is like we have to make involve all the schools and in our locality and make it a routine program and visit schools and counsel them regarding puberty and as well as HPV vaccine.
Thank you.
Awareness improves the treatment.
Thank you. Thank you. Dr. Somalatha?
Yes, ma'am, same counseling and tell them in a smooth way like treatments are available and if early treatment, better childhood.
Okay. Annapurna ma'am?
Madam, though it is seen, we don't see precocious puberty very often, but when we see it, we should identify it in time. Send the child to proper, if we are not qualified or if we are not experienced enough to treat them, send them to proper persons, not let them go because the height of the child is at stake, her future is at stake. So we should be ready to identify and treat her in a proper way. Thank you for the rare topic.
Sreedevi ma'am, would you like to add something?
Yeah. As everybody said, early diagnosis, look for the look for the signs of precocious puberty, early diagnosis, counseling, and counseling. Spend more time with the parent, just parents and also the child. And to the parents, tell them the long-term the risk factors. Then maybe in presence of child, if we tell them, the child also will be convinced and they will comply to the treatment. The answer is early diagnosis, counseling, and we as gynecologists, I feel we are very much, qualified to identify and treat the cases. And I think most of the cases we can treat without referring to the endocrinologist. Only the extreme cases we can we can refer.
Ruchi
That's
ma'am?
what I feel.
I'll take more than half a minute, Dr. Asha.
Yes.
As you rightly said, we need to educate ourselves as gynecologists. If we are working for an HPV vaccine, we have a very anti-lobby vaccine also. Similarly, you can ask any pediatric endocrinologist, Dr. Kartheek or Dr. Saurabh is here, how many pediatricians will refer a case of precocious puberty to them? So often parents are coming in saying, हाँ नहीं ये injection safe नहीं है, हमको तो हमारे बच्चे वाले डॉक्टर ने बोला ये safe नहीं होता. So we need to educate ourselves first. We need to, for the benefit of these children, we need to be firm with the family, but we need to be soft with the child. It's only a 6-year-old, 8-year-old, 9-year-old child. We cannot give them very difficult targets like you do this 30 minutes, you do that, or 40 minutes. We must give them something like you can do some skipping for 100 or 200 counts. You don't need to go out anywhere. If there are stairs in your house, just go run up and down 10 times a day. Some easy targets and be soft on the child. And even if she loses 100 gram weight or 150 gram weight, should be 100 only. It should be, wow, you've lost 100 grams. That's a great job. So we have to teach the family also to be soft on the child, but we have to be firm with the family. But most important is we have to educate ourselves. We have to adopt these new strategies. We must learn to adopt these new strategies so that we are able to give a wonderful future generation, so that we have a wonderful future generation.
Thank you so much. So, Dr. Kartheek, we come to you last before we officially end the session.
Everything is covered, ma'am. But the main thing is we need to tell them early puberty is not normal. We just need to counsel them. And there is no harm in postponing we just keep a barrier. We are just keeping a barrier. We are not interrupting the normal flow. We are just blocking the flow temporarily. And then once the medicine is withdrawn, everything goes back to the normal.
So, thank you so much. Thank you, Kumudini ma'am, Dr. Saurabh, Dr. Sreedevi, Dr. Kartheek, Ruchi ma'am, Dr. Annapurna, Dr. Somalatha, Dr. Sangita, Dr. Jyothi, Dr. Annapurna. Thank you, Sujayasri. Thank you all my viewers for being here. Next week, we are doing autoimmune diseases in pregnancy. So hope to see you again next week, same time. Welcome and thank you. Good night. Have a great evening.
Thank you so
very
much, ma'am.
Thank you.
Thank you.